Hi, good evening. We're going to start promptly at 6 o'clock. So go ahead and make yourself comfortable. Good evening and welcome to the Swindell Center Community Education. I'm Janet and I want to thank you all for joining us. I want to start out this evening by acknowledging and honoring that we reside and serve families on ungifted land of the traditional inhabitants of Oregon who have stewarded it throughout the generations, including the 9 federally recognized Confederate tribes in Oregon. Let this land acknowledgement be an opening for all of us to contemplate Indigenous movements for sovereignty and support their self-determination. For those of you new to Swindell's, we are a resource center that offers support and resources for families, providers, educators, and caregivers of children with special health, development, and behavioral health needs. In addition to trainings like this, we have an online lending library that can be accessed via our website, as well as a free care notebook or organizer, which is a handy tool to maintain a health record for your child and keep all those important documents, business cards in one handy place. For more information on events, to request a library book or a care notebook, please contact the Swindell's Resource Center at swindells@providence.org or at 503-215-2429. I would also like to thank the Providence Children's Health Foundation and its generous donors for help making this event possible. Before I get started, I would like to acknowledge that this training will be audio and video recorded. By joining this training, you are giving your consent to be recorded. Your microphones and cameras are all turned off for your privacy. We will have a Q&A session at the end. If you have questions or comments, please use the chat box. Finally, after the event, you will receive an email within the next 24 hours of the training with an event evaluation. Upon completing the evaluation, you will be sent a certificate of attendance. Again, we are very happy for all of you to join us tonight. Please join me in welcoming Dr. Alison Christy.
Hi, I'm Dr. Alison Christy. I am a pediatric neurologist. I work primarily at St. Vincent's with an epilepsy specialist, Dr. Josh Kim, and with a nurse practitioner, Cynthia Beal, who focuses on headaches and tics. I'm the clinical director of the program, and I am the director of the new Providence Center for Pediatric Multiple Sclerosis and Neuroimmunology, which has been made possible by a very generous grant from a family. My focus is in neuroimmunology. I have a PhD in immunology, but I'm a pediatric neurologist. And fortunately, neuroimmunological problems in children are rare. So I see a little bit of everything. I see tics, seizures, headaches, tremors, the whole gamut of what happens to children's brains. And I see a lot of sleep problems. So today we're going to talk about sleep. I should say, oh, my slide is not advancing. There we go. I should say that I'm not a sleep specialist. There are people who are sleep medicine trained who do extra years after their original training, sometimes from pulmonology or neurology or from pediatrics or psychiatry, who do sleep training and then are sleep trained. I work very closely with these people, but I'm not a sleep medicine specialist, so I just want to be clear about that. But sleep comes up in basically every single clinic visit because it affects so much of what we do in neurology. It affects the brain so much. And I also want to say that I have 2 children, and I'll tell you a little bit about my son. He, when he was born, he slept 20 hours a day, which can be normal for a newborn. By the time he was about 6-8 weeks old, he was sleeping 6 hours a night. He has always been a great sleeper. You just put him to bed and he goes right to sleep, and it's really wonderful. And if I had only had this one child, I would tell you that I know everything about sleep and sleep training. Cry it out is easy. You just put kids in the bed, you turn off the light, they fuss a little bit, they go to sleep. What's the big deal? But fortunately for you, I also have another child. My first child is my daughter, and she has always been a kind of terrible sleeper. She's a lovely person. She's very smart, and she has always been difficult with sleep. When she was really little, she would wake up frequently at night. We did a lot of co-sleeping and a lot of nursing in the middle of the night and a lot of the things that you're not supposed to do because we were so tired and we were so at the end of our rope. And so I definitely have an appreciation of how important sleep is for your functioning, and how so much of whether or not your child is a good sleeper is dependent on the child that you have. And that means that I'm not going to be able to tell you something that works for every child. I wish I could. The fact that there are a million different books on sleep in the bookstore can tell you that not everything is going to work for every person, or else we wouldn't need those books. That also means that your mother is probably not the person who can tell you exactly what's going to work for your child. Your best friend can't tell you what works for your child. A lot of this is just sort of figuring out what kind of kid you have and what they need. Right now, my daughter is 10, and she goes to bed with a sleep mask and white noise machine, and she knows that her bedtime is sacred. If she's at a sleepover, she's like, okay, guys, I'm going to go to bed now. She knows that. She knows that she needs to get her regular sleep, or else it's not going to work well for her. And even now, sometimes she wakes up in the middle of the night. And I should say she's a neurotypical child, no issues, but sleep has always been one of her things. And my son, who is also neurotypical, he's now 8. He is still this perfect sleeper, and that's just who he is. So let's get into and I would also like to say that I don't give a lot of talks about sleep. So I talk about headaches, and I talk about seizures, and I talk about neuroimmunological issues, but sleep is something that I deal with very frequently, but I don't give a lot of talks on it. So if this is not the talk that you were looking for, if there's something else you want, please let the folks at Swindells know when you get that survey, because we can do this again. We could do this again in a few months and maybe answer your specific questions if this is not the talk you were looking for. So sleep is important. And if you're here, I think you know this. The brain does this amazing thing. So the brain basically electrically can be either awake, falling asleep, or asleep. And that's kind of what it does. And when we look at the electrical activity of the brain, there's this wonderful conserved pattern of being awake, going into rapid eye movement sleep or active sleep, and then going into deeper sleep or non-rapid eye movement sleep, non-REM sleep. The fetus around 20 weeks gestational age, so 27, 28 weeks from the time of conception, has almost exclusively rapid eye movement sleep. And as you grow, you have less rapid eye movement sleep and more of that deep sleep. And this N3, this deepest of sleep, is when growth hormone is released, and so is very important for children. It's actually kind of amazing that the brain can go through these patterns and cycles. And it's not simple. There's a lot of different things that go on in making the brain fall asleep and making all of those patterns work well. So it's not something where I can say, oh, you have an increase in dopamine and then you fall asleep and everything's great. It's a much more complicated circuitry. So we frequently see that when children have neurodevelopmental abnormalities, they also have problems with sleep. It gets into kind of a chicken or the egg pattern, because obviously, if you're not getting good sleep, it could affect your development. But if your brain is different, then these complicated pathways get messed up. And so you're going to have worse sleep too. And we don't generally find that if we aggressively treat sleep and make sure kids fall asleep with medicines, that we necessarily improve their development. Because again, these things are just so intertwined. And the fact that we have a whole bunch of different medications, again, will tell you that this circuitry isn't simple. It's not just like you need X and then you get Y. It would be nice. The brain is never like that. You know that sleep is important for you. And if we don't get sleep, you have decreased cognitive function and decision making. Your frontal lobe essentially shuts down. And so your emotions are heightened. You're going to make bad choices. You have increased inflammation in the brain, but then decreased inflammation in the rest of the body. So a decreased immune response. You get a hunger hormone imbalance. So usually you're hungry. And I can tell you as a physician, after 28-hour calls, I would be starving, and it would be, again, poor decision making on top of hunger. So then you just want to eat all the carbs and all the bad things because you just feel so bad. Decreased clearance of toxic proteins. And by that, I don't mean toxins like the things that you get from your environment, But during the day, when your brain is working, it basically generates some trash, and that trash has to be cleared out at the end of the day through a pathway we call the glymphatic system. You lose vigilance and attention, and we think sleep is important for incorporating short-term memory into long-term memories, so you get decreased long-term memory. One time when I was post-call after a 28-hour shift, my husband picked me up and he was like, could you just watch the kids at this playground for a little bit while I run an errand? And I was fine. And then all of a sudden I felt absolutely like I was drunk, like the world was moving. I felt completely unsafe watching my children. It's kind of amazing how much the lack of sleep affects our brains. And kids are different. So you or I, we get tired, we're kind of cranky, we're kind of groggy, we yawn a lot. Kids can get really hyper, and it can actually be more difficult to put them to sleep if they're overtired. And if they have a sleep disturbance and are chronically overtired, it can get very difficult to put them to sleep and get them to have good sleep. Kids who are impulsive, kids who are hyperactive, kids who have a diagnosis of ADHD, we're often thinking about what is sleep messed up? Is sleep a problem here? So I mentioned that many children with neurodevelopmental differences have a lot of trouble with sleep, so that's something that we address in my clinic. Mood disorders are also associated with poor sleep. And again, it's a chicken and the egg question, because if you're depressed and have anxiety, then oftentimes your sleep is going to be disturbed. But disturbed sleep can also aggravate depression and anxiety, right? So are you lying awake because you're anxious, or are you anxious because you're lying awake? Those two things kind of go hand in hand. We do see that if we identify and address mood disorders, that oftentimes we can improve sleep as well. Seizures. I deal with a lot of children who have brain abnormalities and have seizures, and if they are not getting good sleep, then seizures will occur more frequently. It's a big trigger for seizures. And it's not generally the cause of seizures, it's the thing that is going to make them happen more frequently. But I certainly don't want to give you more medication for your seizures if the real problem is that you're not getting good sleep. And then, of course, the other thing we see a lot is headaches, and lack of sleep is a big cause of headaches. And I'm sure that if any of you are headache people, you absolutely know that is the truth. I get this question a lot. How much sleep does my kid need? And the answer is pretty broad. As you can see, the numbers change. You need less sleep as you get older, but 13 to 18-year-olds still need 8 to 10 hours of sleep. How many of them are actually getting 8 to 10 hours of sleep a night? Very few. And usually that's a behavioral thing and not a thing of an actual sleep disorder. They want to stay up late because that's the fun time, and then they want to sleep in and they need to get up to go to school. And there's an actual biological shift that happens in adolescent brains where the children who are little biologically want to go to bed earlier and get up at a regular time. And as they get into teenagers, they naturally phase shift and want to go to bed later. And then with school in the morning, that makes things difficult. But there's a broad range. So your kid may not need the amount of sleep that you think they do. They may need more and they may need less. And the main way you can tell that is, what are they like? What are they like during the day? Do they seem like they're tired? Do they fall asleep when they are watching TV or when they're in a car? I worked with a sleep medicine doctor once who said, anyone can stay awake if there's a gun held to your head, right? And some people live their lives like that all the time. And then as soon as you start to shut down, as soon as you're watching a movie, as soon as you have a time when you're kind of relaxed, you fall asleep. And if you're just bored, you don't fall asleep, you think about other stuff. But if your sleep is off, if you're really tired, you're going to fall asleep. Kids don't always fall asleep, though. And again, that gets back to the thing that they can be hyper, they can be crazy, they can be impulsive, they can make poor choices because their frontal lobe is shut down because they're not having enough sleep. We're going to talk about what can go wrong with sleep today. And the main things are parasomnias, things that go on in the middle of the night during sleep, excessive daytime sleepiness, and insomnia. So parasomnias are really common in kids, and the main types are confusional arousals, sleep terrors, and sleepwalking, and we're touching on nightmares as well. And these are all things that happen in active sleep, in the REM sleep. Confusional arousals are most common in toddlers. They usually last about 5 to 30 minutes, and they're exactly what they sound like. Kids sit up and they're confused. They often seem distressed. You can't really console them. They seem like they're not really there. and they don't remember it in the morning. And so it bothers the parent, but it very rarely bothers the child at all. Sleep tears happens a little bit later. So after the toddler period where you might have confusional arousals, you get these sleep terrors. Kids will wake up, they'll be screaming, flushed face, rapid heartbeat. They look like they're in the fight or flight mode, right? Their autonomic system is completely activated and they're ready to go. They look like they are terrified, and it's really hard on parents. And if they're screaming, then it also is hard on all the other kids in the family because it's really loud and upsetting. It usually lasts about 10 to 40 minutes. And generally, again, kid won't remember the event in the morning, won't be super tired. It's just they're cool with it, and everyone else is the one who's upset. Advancing. There we go. Sleepwalking is a little bit later and happens around 8 to 12 years of age. These are broad, so if you had a 7-year-old, I wouldn't be shocked if they're sleepwalking. And what happens is they get up and they wander, and they may do things like open the door, open a window, things that could be dangerous. And then nightmares. Nightmares are bad dreams, right? And bad dreams generally are not going to hurt you, but sometimes with children, they can lead to daytime distress. I'm sure we all have had the experience of having a bad dream that then sort of lingers on in the day, and you just feel bad during the day as well. And it can sometimes lead to sleep resistance. Like, I don't want to go to bed because I know if I go to bed, I could have a nightmare and it could be upsetting to me. We worry about these. Oftentimes when I see people in clinic, they're worried about these because they're worried that they might be a seizure. And there are a couple of different types of seizures that happen only at night. Frontal lobe epilepsies are not very classically like a seizure, and so could look like something like a night terror or confusional arousal. Generally, they are going to be about 1 to 3 minutes, and they're going to be stereotyped, meaning that they look the same every time. So they can be strange where the child is sitting up and, say, grabbing at the air or saying strange things or rocking and apologizing or things like that. But it would kind of be the same way every time. And if it's something that's classically like a night terror, confusional arousal, it's lasting longer than this period. If it's classic, I'm not generally very concerned about it being one of these epilepsies. Benign Rolandic epilepsy generally presents in the ages of around 6 to 10. Kids will have a facial droop generally and a lot of drooling, and they'll be alert and distressed and unable to talk. So they look kind of like someone who's had a stroke. This is a very common epilepsy in children. It's not one that we actually have to treat because children will grow out of it, but generally we do treat it nowadays. So if that is something you're concerned about, you should certainly talk to your pediatrician about seeing a neurologist. Sometimes these parasomnias can be a sign of sleep disorders because they tend to happen when kids are tired. So if kids are tired because their sleep is disturbed, then these things are more likely to happen. These confusional arousals, these night terrors, and even things like sleepwalking, sleep talking. That's often something I'll ask when I'm worried about something like sleep apnea or other sleep disturbances. And the other question is, are these disturbing your kid? Does your kid seem tired during the day? And if your kid is having these parasomnias and also seems to be not right during the day, then you should probably talk to your pediatrician about seeing a sleep specialist. This is a cartoon what normal people are like when they're a little tired, and then what small children are like when they're a little tired. This foul language comics, they really get sleep, I think, when it comes to toddlers. What do you do if your kid is doing this? The main thing is to make sure that they get enough sleep because, again, if they're tired, these things are going to be more likely to pop up. And consider taking them to a sleep medicine specialist to look at sleep apnea or other things that might be disturbing their sleep. You want to keep your kids safe. I mean, that's really the most important thing. So if they are sleepwalking, sometimes there are things that you need to do, like put up baby gates or lock the door. If they're sleepwalking, it's not going to bother them, right? But we don't want them to get hurt. A scheduled waking can be helpful. If you know that your child has a night terror every night, it's usually in the first part of the evening. So if you know that they always have a night terror an hour after they go to bed, if you wake them up at 45 minutes after they go to bed, you get them out of that sleep cycle and you can actually prevent the things from happening. So that is a very nice way of doing it. Getting a video can be very helpful. And honestly, as a neurologist, videos tell me so much about the things that you're worried about with your kid. So if there's anything you're seeing and you're like, man, that looks weird to me, take a video, man. I can say so much from a video, whereas sometimes when parents are describing something to me, I really don't understand exactly what they're talking about. So you've got a phone, take a video. You can always send it to your pediatrician, or you can send it to a neurologist. And there are medications that can help with these parasomnias. They tend to be blood pressure medications. Obviously, we work with children. We try not to use medications unless we absolutely have to. But sometimes, if these are really distressing to the child and the family, that's something that we'll do. So excessive daytime sleepiness, when your kid is always tired. And this is something that I see a lot. And most of the time, it is what we call behaviorally induced insufficient sleep syndrome, which is such a funny long term for your kid isn't getting enough sleep, so they're always tired. That doesn't mean that they are just up looking at their phone at night. That means that sometimes they have anxiety, or they have PTSD from some trauma that they've had, or they've gotten into a pattern of going to sleep late, or the kitten is always eating their feet at night, and so they can't fall asleep. This just means that there's not really a sleep disorder. It's just that they're not getting enough sleep, and so they are always tired. And that's most common. But sleep apnea is also a common thing that we'll talk about in children. Circadian rhythm disorders, narcolepsy, idiopathic hypersomnia, which means super sleepy and we don't know why. And then periodic limb movement disorder are all things that can cause excessive daytime sleepiness in kids. So oftentimes to evaluate these things, we would do what we call a sleep study, or a polysomnograph, or a PSG. And I can order these studies. I don't read them myself. If they are abnormal, then I would generally send you to a sleep medicine specialist to talk to them about sleep apnea or restless legs or things like that. So what you get an electroencephalogram. They put electrodes on your head and measure your brain waves. So to see those different sleep stages. It's not the same as the EEG that we do if we think you're having seizures. So having a normal sleep study doesn't rule out seizures. Sometimes the sleep medicine specialist will call me and say, we did a sleep study on someone and we were seeing things and we think that they might be seizures, but it doesn't really work the other way around. We can't really say for sure that it's not a seizure from that. For that, we would put electrodes on your head we put more electrodes on your head and measure your brain waves. And that's something we can definitely do in neurology if you're concerned about seizures at night. You get an electromyogram looking at your muscle activity. That's because when you're in the REM sleep, the rapid eye movement sleep, your muscles should be paralyzed. They should be completely inactive. So that is a way of measuring whether you're having appropriate REM sleep and whether you're in REM sleep. We look at eye movement. So that again tells us whether you're in rapid eye movement sleep. It's a way of characterizing it. We look at your heartbeat. We look at nasal pressure. So when you're sucking in air through your nose or not. We look at the oronasal airflow. So even if you're not breathing in through your nose, if you're breathing in through your mouth, we're trying to see where the air is going. You look at how much CO2 you're breathing out. We look at how much oxygen is in your bloodstream. We look at chest and abdominal wall motion. Because if you have sleep apnea, you're breathing in air and your chest is trying to move, but it can't because there's something blocking the way if it's obstructive sleep apnea. And we look at the positions of the body. And then, of course, there's also a video. So you can characterize how much movement there is, what kind of positions the body is in. You can see how the breathing is going, how the heart rate is going. You can see a lot of things in the sleep study. So it's a very useful test. It gives you a lot of information. People ask me a lot about Fitbits and wrist sleep trackers. Those are technically for entertainment purposes only. They will tell you if your kids said they went to bed at 9 and you can see that they were still up until 10, that will tell you that. It can help encourage you to go to bed at the same time every night. It can help encourage you to get activity during the day, which usually helps with sleep at night as well, getting good exercise. It doesn't really tell you a lot about sleep pathology. I often have people come in and they say, well, I put a Fitbit on my child and they were up all night. They never got any sleep. They never went into REM sleep and I'm freaking out. And what that really tells me is not that your child actually necessarily has a sleep disorder, but that you are concerned about your child and you are concerned about specifically their sleep. So that tells me that we need to talk more about sleep. We need to talk about getting a sleep study. We need to talk about sending you to sleep medicine if that's necessary. We need to figure your sleep out because you're concerned. But the sleep tracker, unfortunately, is just not it has not been validated. It is not as good as we would like it to be. And of course, you're not getting all those other things that you would get in a sleep study. Sleep apnea, when we think about adults with sleep apnea, we think about someone who's heavy, someone who has a thick neck, and then what happens in the REM sleep is that your muscles become weak, they become paralyzed, and you get a collapse of your neck, so air can't get through, your tongue's fallen back, everything's sort of collapsed in on itself, and you can't get air in through the airway. And kids tend to not be quite classically like that. Kids tend to have problems with their tonsils and adenoids that block the airways during sleep. These are immune tissues. They get larger around age 8 to 10, and the head and neck haven't gotten larger yet to accommodate them. So as a child is trying to breathe in air during the night, it's not getting past that lymph tissue that's in the way. Sometimes you do get snoring like you would with an adult. You can have episodes of not breathing where the child wakes up and is startled. But kids tend to be more subtle than adults are. So if you tell me they can't have sleep apnea, I never see them snore or wake up during sleep, it's not necessarily the case. Mouth breathing can be a sign of sleep apnea, restlessness during sleep. Parasomnias, like I mentioned, can come when you're tired, so can come with sleep apnea, and bedwetting can come with sleep apnea as well, because you're just so tired that you're just not able to rouse yourself appropriately when your bladder is full. This is going to be diagnosed primarily through a sleep study. However, because the main treatment is a tonsillectomy and an adenoidectomy for obstructive sleep apnea, you can also just go see an ENT or an otolaryngologist. If you have a private insurance, generally you can go straight to an ENT. If you have OHP, then generally they do want a sleep study before they'll say that you have your child has sleep apnea and needs a tonsillectomy. The sleep study would determine whether the apnea is obstructive from something like tonsils or central. Central sleep apnea means that the drive to breathe goes away during sleep. So the air is not being sucked in at all, it's just stopped. This is less common. It is something that happens in children who have neurodevelopmental differences. Children have differences about their brains. They can have central sleep apnea. And then the main treatment for that is going to be something like a CPAP, like we use for adults, that pushes air in and forces the person to keep breathing even when they stop at night. And that can be very difficult, especially with a lot of the kids that we see who won't tolerate something like a CPAP. Like it's pretty complicated if it's not something as simple as taking the tonsils out. Children at risk for sleep apnea. So basically, a lot of the things that I see in the clinic are going to put kids at risk for sleep apnea, including Down syndrome, which often has structural changes about the head and neck that can make sleep apnea more common, and also a weakness of the muscles. Neuromuscular disorders, when the muscles are weaker, you're more likely to obstruct your airway when you're sleeping. Epilepsy, both can increase your risk for sleep apnea, and then sleep apnea can make seizures more likely to happen. Cerebral palsy, obesity in children, Chiari malformations can increase your risk of having a central sleep apnea. Having headaches can be a sign of sleep apnea. ADHD, again, can be misdiagnosed and can actually be sleep apnea. Having a traumatic brain injury, obesity again, and craniofacial abnormalities, which can go along with brain abnormalities as well. So a lot of the children that get referred to neurology, again, we're going to be talking about sleep. We're going to be talking about sleep apnea because they are at risk. Circadian sleep-wake disorders. So the circadian rhythms are so fascinating. So you have probably heard of this before when you, if you were living in a room and there was no light or dark stimulation during the day, and it was always light or always dark, you would go to bed at a certain time and wake up at a certain time, and that would get later every single day because your natural circadian rhythms are actually different from the rhythms that we get from the sun and from the light and dark cycles. We call the input that teaches our bodies to wake up and go to sleep at a certain time Zeitgebers, which is German for time giver, and that the main one is light. So having bright lights in the morning, having dim lights in the evening helps with your circadian rhythms because it tells your brain when it's time to be awake and when it's time to go to sleep. There are other Zeitgebers like what you eat and when. For instance, if you're eating really late, then you're telling your body now's the time to be awake. Things like exercise, All of these things contribute, but if you aren't getting light input, then that can create problems with your circadian rhythms. And so this is a chart of a person living with, this is a person who has a light-dark cycle that is artificial, with lights turned on and lights turned off. And this is where they're living in a all light, all the time environment. And so the circadian rhythms are off. Children who don't have vision, children who are blind, or children who have abnormalities in the brain that affects the processing of light, oftentimes will have a lot of trouble with circadian rhythms and a lot of trouble with sleep. There are intrinsic circadian rhythm disorders, primarily delayed sleep-wake phase disorders, the one we see in children where they naturally want to go to bed later and wake up later. Advanced sleep-wake phase disorder, less common in kids. That would be where you'd want to go to bed earlier and wake up earlier, and it's not responding to the Zeitgebers around you. A non-24-hour sleep-wake rhythm disorder or a regular sleep-wake rhythm disorder, both of which tend to involve people just feeling randomly tired and falling asleep, and vice versa, waking up when they shouldn't. And there are extrinsic causes of circadian sleep-wake disorders, including jet lag and shift work. And if you're concerned about something like this in your child, then you're going to want to speak to your pediatrician about a referral to a sleep specialist. And again, they would do something like a sleep study. The main treatment for these is going to be melatonin, which we'll talk about in the evening, and then bright lights in the morning. And that is, again, just to really drill in those Zeitgebers, to really give you the information that your brain needs in order to correct your circadian rhythms as much as we can. Narcolepsy is one of my very favorite sleep disorders. There is a area in the hypothalamus that releases a chemical called orexin, a protein called orexin. It was discovered at the same time by two different groups. And so one group called it orexin and one group called it hypocretin. And they just sort of fought it out. And for the most part, we call it orexin. And it's not something as simple as if you have orexin, you're awake, or if you don't have orexin, you're asleep. It sort of tells your brain the difference between wake and sleep states. So if you think of the brain as like a seesaw, it can either be awake or asleep. And the orexin neurons are important for telling the brain that it's in the awake state versus the sleep state. And if you lack orexin neurons, if you don't have orexin anymore, then you're stuck in this middle ground where you're sort of in between sleep and wake. So you get sleep phenomena during the waking time, and you get waking phenomena during sleeping time. It's thought that this might be an autoimmune disease, but it's an autoimmune disease kind of like diabetes or thyroiditis, where you don't treat with anti-inflammatory medications. You treat instead by trying to fix the symptoms, trying to fix the problem that's existing. One type of narcolepsy involves something called cataplexy, where if you feel strong emotions, usually positive emotions, like anger or laughter, then you can have paralysis. And sometimes that means someone's laughing, they fall on the ground, they can't move their body. Sometimes that means that they just have a droop to their face, or their whole jaw goes slack, or their arms go weak. And everyone just thinks, oh, it's so funny, whenever my friend laughs, he looks kind of weird. And then and no one really recognizes that it's narcolepsy. And narcolepsy often goes misdiagnosed in the teenage years. And that can be a problem because it's associated with things like depression and overeating. So cataplexy is one thing that can go along with narcolepsy. Sleep paralysis is not necessarily narcolepsy, but it can go along with it. And that's where you wake up and you're unable to move, but you're still awake in the bed. Hallucinations while falling asleep or waking up, which we call hypnagogic or hypnopompic hallucinations, that seem like a waking dream. So again, you're awake, but you're in a dream state, which is unusual. Sleep attacks, where suddenly you're sitting there and the next minute, for instance, if you guys are falling asleep listening to me, I wouldn't call that a sleep attack. But if I fall asleep right now while I'm on camera, then that qualifies. Sleep that comes out of nowhere in a weird time. Frequent nighttime waking, because again, it's not just a problem of hypersomnolence. It's not just a problem of falling asleep during the day, but the sleep is also not normal because you're in this state of between waking and sleeping all the time. The way we diagnose this in adults is primarily with a multiple sleep latency test. They have you come in and do the polysomnography overnight. So they make sure that you get a good night's sleep. because it can be this test can be made invalid if you are chronically sleep deprived and you haven't gotten enough sleep. So they make sure you get a good night's sleep, and then they have you fall asleep repeatedly during the day. And with those naps, they look at how long it takes you to fall asleep. That can be messed up, as I said, from being chronically sleep deprived, and it can also be messed up if you are on certain psychoactive medications. So what we do sometimes in kids is a lumbar puncture. The MSLT also isn't entirely validated in kids, so I do lumbar punctures for the sleep group at OHSU, and what we're looking for is this chemical orexin, and I can send us a test to Mayo Clinic, and if you have narcolepsy, then orexin is vanishingly low, and then you have a diagnosis of narcolepsy. And then generally the way we treat it is with either stimulant medications like Ritalin or Adderall, or Provigil, or other medications that will keep you awake during the day, and then medications that help you sleep at night. Because again, we can't really go in and fix the underlying problem necessarily. It's mostly about treating the symptoms at that point once you have the diagnosis of narcolepsy. Periodic limb movement disorders and restless leg syndrome is a question I get a lot from families because kids move around a lot during their sleep. And again, the Fitbit is not necessarily going to tell you if this is the thing that's going on. These things are connected. They're not quite exactly the same thing. In restless leg, the person is still awake and they have this urge to move their legs. So as soon as you lie down and rest, or while you're sitting here listening to me, you just feel like this urge in your legs, and it only stops when you move. So it keeps you from falling asleep because you can't just rest and let your legs stay still. Periodic limb movement disorder is when you have movements during sleep that are excessive, as well as the fatigue during the day that tells you that that's a problem. Because sleep is only a problem when it is, right? So if your kid moves all night long and they're not tired during the day, it's not necessarily a problem. If your kid moves frequently at night and they are tired during the day, then it is. And again, this is something that would be tested during the polysomnograph. And generally, we start off by trying to treat with iron and vitamin D. Many children who have restless leg syndrome or periodic limb movements are low in iron. Even if they're not, that's often where we'll start with treatment. And vitamin D is another thing that's been shown to be very important for general health and generally low, especially here in Portland. But honestly, everyone is low with vitamin D all the time unless they take a supplement. So generally we start with iron and vitamin D. So if it's a concern that you have with your child, then starting with something like these supplements would not be an unreasonable place. There are also medicines that can be helpful with it. Again, things like blood pressure medications, sometimes things like just the same medications we use for Parkinson's that increase your dopamine. And you can talk to a sleep specialist or a neurologist about that. Insomnia is the third thing that we're going to talk about that can go wrong with your sleep. And this is one that is a frequent concern as well. Insomnia can mean a difficulty falling asleep. It can also mean a difficulty staying asleep, where people wake during the night and stay awake. And if you recall that graph from the very, very beginning, where we talked about how you're awake and then you go into rapid eye movement sleep and then you go into deeper sleep and then back up again, everyone wakes periodically during the night. And for the most part, we fall right back asleep and don't remember that. Some people do remember it and it bothers them and it makes them feel subjectively like they haven't gotten enough sleep. And some people wake up and they actually stay awake, and then that's a problem, and that counts as insomnia. Early morning waking, where you go to bed at the regular time, but then you wake up early. This tends to be a problem of the elderly, but they wake up and can't fall back asleep, and then they're just kind of up for the day. And then what's called non-restorative sleep insomnia, where you are there and you're sleeping, but it never feels like it's enough. It never feels right. This often goes along with something like pain disorders, fibromyalgia, sometimes with multiple sclerosis, and sometimes with things like anxiety and mood disorders as well. But that counts as an insomnia if you are simply feeling like you're just never getting enough sleep, even though you slept the full night. I would say if you feel like you never get enough sleep, even though you slept a full night, then also a sleep study is probably a good idea to make sure it's not something like sleep apnea, which again can be subtle, and make sure that the sleep that at least appears to be normal. Generally, when we talk about insomnia, we talk about sleep hygiene. And probably if you are here and listening to me talk about sleep hygiene is not a new concept for you. It's not going to be everything for everybody. It's not going to fix all of your problems. But in general, it is difficult to fix problems with other resources unless this basic sleep hygiene thing is tucked in. For instance, I see a lot of people with headaches and I say, you should drink water. And they say, well, I drank water and it didn't help. And I say, okay, but like, I can't do anything else about your headaches if that water piece isn't there, right? It's just the basics. It's safe, healthy, natural, it's cheap. And we just have to do this so that we can then say, all right, that's tucked in. We're going to address this in other ways. Same with sleep hygiene. Generally, people need a consistent bedtime routine. And I said in the beginning that not everything works for everybody. But in general, the human brain responds to consistency. The same thing every time. If you are trying to discipline a toddler, you have to make sure that they never get you to say yes, ever. If you're saying no, it always has to be no, or else they know that if they fuss enough, then they could win. And it's the same with sleep. Your brain is basically a toddler when it comes to sleep. I mentioned that my daughter has to have her sleep mask and her white noise machine, and she has to go to bed on time, and she knows that she needs her consistent nighttime routine or else she's going to have a problem falling asleep. No screens 30 to 60 minutes before bed. That means no phones, don't put it on light mode, don't put it on night mode, don't put it on like blue light mode. All those things, they just give that circadian input to your brain. It's a great Zeitgeber, and also it's just so stimulating. And you can be on call for 24 hours and you can still play games on your phone because that's what they're designed for. They're so exciting. They're like, they always bring you to the next thing. So it's a bad idea. One sleep talk I went to, they even said a Kindle is a bad idea, even though a Kindle doesn't really have a light source, but they felt like books are just generally better. So no screens at all. And you're not special. Your brain isn't different. You need to not have the light source and the phone before bedtime. And if you're here because you have a teenager who won't sleep, you can tell them I said this, no phones before bed. And ideally for teens, having the phone out of the room is very helpful too, because even if they are just sort of waiting for the next text while they're falling asleep, that can really disrupt sleep because it's kind of a heightened anxiety. Dim lights before bed. Again, it's for the circadian input, and follow the same steps every night with your kid. So every night you have them brush your teeth. Every night you read the story. Every night you go through these steps. And that is hard in today's world, right? Because there's all these things that make life different. And I can tell you that for my personal family, we don't stay up for New Year's, and we can never go see one of the fun movies in the park in Portland because they start at 9, and we have to have our general sleep routine or else things get iffy. Again, for my daughter, for my son, it'd probably be fine. He probably would fall asleep. He's just a really good sleeper. Having a sleep schedule with a fixed wake up time is very important. So teenagers tend to sleep deprived through the week and sleep in a lot on the weekends, and that is going to make them feel crummy. Generally, in order to improve sleep, you're going to want to have a time where you wake up at the same time every day, and maybe you sleep in an hour on the weekends, but you don't sleep in until noon. If you're taking naps, which can be good, they should be short, because otherwise you're going to eliminate your sleep pressure. Basically, you're clearing your brain of adenosine, and so you are going to have trouble falling asleep if you are taking a longer nap, or if you are taking a nap that is closer to bedtime. And this is true even if you're tired, because what tends to happen is that you have a bad night of sleep, and then you're like, well, I'm just so tired now, so you sleep in, or maybe you take a nap. And then the next night you have a bad night of sleep too. So even if you have a bad night of sleep, it's important to have that consistent wake up time so that you can get your sleep back on track. Sleep specialists recommend focusing on relaxing instead of focusing on falling asleep, because that feeling of I can't sleep, I feel so terrible, I can't sleep, it's not very conducive to falling asleep, right? And it really builds a lot of anxiety. So focus on just relaxing your body and just think about relaxing. Eating and exercising late, like I mentioned, that's a big Zeitgeber, so that's going to tell your body that it's time to be awake, and you don't want that either. Caffeine, no caffeine in the afternoon or evening. It's kind of a no-brainer, right? But it's still a thing we have to say. And then alcohol, of course, can put you to sleep, but it's not going to help you stay asleep. In fact, very frequently people will wake up and then lose their sleep pressure and have trouble sleeping after drinking alcohol. Bed is for sleeping and for sex and for nothing else. That's generally the plan. And obviously sex, I'm talking about adults, not for kids. But generally, bed is a place where you sleep, and you don't want to spend a long time lying in bed awake and not unable to fall asleep. But at the same time, you don't want to get up and start unloading the dishwasher or doing crafts, something that's going to keep you awake. You want to do something that's very low key, low dim lights, maybe read a book, something that's not going to cause a lot of brain stimulation. The main treatment for insomnia that has been tested and is approved by the American Sleep Association is cognitive behavioral therapy for insomnia, or CBTI. Medications are not generally recommended by the sleep specialists. This is the thing that will help you get off medications and going to sleep. And again, I'm sort of addressing more the adult component of this here, although I think it is helpful for kids as well, teenagers. This is, of course, mostly going to be helpful for teenagers who can process behavioral therapies, right? There are teens that can't. This book was recommended to me by some sleep specialists, Say Goodnight to Insomnia. It talks about the cognitive behavioral therapy and what is used in the therapy. And then you generally do 3 to 6 sessions and address these issues. It's not the same thing as sleep hygiene, although sleep hygiene is an important component of it, and it can help you get over your issues with sleep. And then there are a bunch of other things that we use, things like I mentioned chronotherapy, where you're using something like melatonin and light to shift your clock, biofeedback, sleep restriction so that you make sure that you're getting up and you're falling asleep at the same time, sleep hygiene, enhanced sleep environment, cognitive therapy, all these things are going to be helpful with insomnia. Medication is kind of a last resort when it comes to kids, but again, many kids who have neurodevelopmental problems are going to need medication. Maybe not your kid, and I think that going through all the other steps before we get there is very important. But some kids are going to need medicine either temporarily or long-term for sleep. Like I mentioned, some kids who can't process sight gabers are going to need things like melatonin. Melatonin can be good for helping shift your sleep as well. So melatonin is released by the pineal gland about 3 to 4 hours before you go to sleep. It's not generally a strong hypnotic. It's not a good sleeping pill. It's not going to knock you out. It's generally better for shifting your clock. And more is not necessarily better either, because you can kind of override your sleep clock. What happens very frequently is people are taking too much and they're taking it too close to sleep. And if you're taking melatonin at 1 in the morning when you couldn't fall asleep, then you're telling your brain that 1 in the morning is kind of your bedtime, and that's not a great thing for long term. Generally, you want to be taking it routinely, 1.5 to 3 milligrams about 2 hours before you go to bed. And that helps your body recognize that that time is your bedtime. It is, it's not something you couldn't push through. It's generally, it's just kind of telling your body, your brain, it's time to shut down. And that's generally going to be the best way to use it. For instance, if you have a teenager who is trying to get their sleep cycle back in sync to go back to school. Ideally, you've addressed this a month before and you have plenty of time and you can just gradually shift their sleep cycle back to where it needs to be. But if you didn't do that, then melatonin can be really helpful for that sleep shift. I don't have a particular brand that I use. The sleep medicine specialists recommend that you have it USP verified. Of course, anything that's a supplement means that we don't have FDA control over it, so I don't know exactly how well it works or what will be best for you. Other things that people use, chamomile tea could be very safe and may work well as a part of a pre-bedtime routine. You know, you have your tea, you brush your teeth, you have your bath, you go to bed, that kind of thing. The warm, hot tea can be really helpful for that. Magnesium, certainly we recommend it for kids who have headaches. It helps relax your muscles. And sometimes it can cause loose stools and you don't want to be getting up in the middle of the night to use the bathroom. So that is the downside to it. A lot of people ask me about Calm, which is a particular magnesium supplement that is available in a drink form for smaller kids, and I think that's totally fine. If they're getting looser stools or if they're complaining of stomach upset, just back off on it. Lavender is fine in a topical formulation, I wouldn't use lavender as something to that is inhaled in the air or eaten. Valerian is an herb that is similar to a seizure medication that we use, Depakote or valproate. In general, the American Sleep Association doesn't recommend it, and I wouldn't either. It can cause some side effects. It's not recommended for pregnant women. I would just stay away from it in a child. And same with L-tryptophan, because it can have some side effects and can interact with some medications. The American Sleep Society doesn't recommend that at all. If you are that desperate that you're thinking about using those things, then I think that you should talk to your physicians about possible medications for sleep. And sometimes we do use these medications in kids. Blood pressure medications can help kind of just chill you out. Guanfacine is one that you use for ADHD or for tics, and clonidine as well. And they can help you fall asleep, and they can help with those parasomnias too, because frequently what happens is it seems that the blood pressure spikes during sleep, and then it alerts the brain that something's wrong, and that's when you get nightmares, that's when you get night terrors and that kind of thing. Some antidepressants we use at a very small dose, much less than we would use for depression. Doxepin, amitriptyline, and trazodone are some main ones that we use as a nighttime dose to help your child fall asleep. In general, if you're using something like trazodone at that point, I would want you to see a sleep medicine specialist. But amitriptyline is something we prescribe for headaches. It makes you drowsy. It seems to work really well for a lot of teenagers. Ciprofloxacin is an antihistamine, and like Benadryl, so it makes you sleepy and it makes you hungry and can help with headaches and may even help with that tonsillar hypertrophy that gets in the way of sleep and makes sleep apnea worse in kids. So it can be a good option, especially small children. And gabapentin, which is a medication that was designed for seizures, but actually works better for nerve pain, also has a sleepiness component to it. So if pain is keeping people up, or for restless legs, that can be a good option. And generally, we start all these medications at the absolute possible smallest dose, because we're just trying to make life a little bit better. And we don't want any side effects. We don't want anything. We don't want any adverse events. My final thing is that sleep is a problem when it causes a problem. So if you think that someone else's kid is having bad sleep, that's not really helpful. If it's only a problem if they are, if it's a problem for the family. If you think someone's doing something wrong with their kid, or someone thinks that you're doing something wrong with your kid, as long as it's working for you for sleep, then it's okay. With the exception of things like co-sleeping with very small children, because you can roll over them and that can be very bad neurologically. So I don't recommend that. But in general, what works for you is what works for you. If it works for you to sleep in bed with your 8-year-old, as long as you're getting good sleep and they're getting good sleep, that's okay. If your kid is having night terrors every night and it doesn't bother you and it doesn't bother them and everyone's still getting good sleep, then that's okay. But if it is a problem, then it's a very important problem, because if your child isn't getting good sleep, then everything is going to be off and they're going to feel miserable. And if you're not getting good sleep because your child's not getting good sleep, man, are you going to feel miserable too? And then everyone's going to be miserable. And this is mostly a discussion of sleep for children, but getting help is important. And if you need someone to watch your child so that you can get some sleep, really, it is a situation of putting on your own oxygen mask. We as parents always put ourselves last, but you can't really put your child first without addressing your own sleep and making sure you're getting rest. I know that is easier said than done. I absolutely understand that. And again, I'll mention that I have a terrible sleeper in my family, but I really recommend that you ask for support if you're having a lot of trouble with your sleep and your kids' sleep. So that's the talk. I'm looking forward to your questions. And again, if this is not the sleep talk you are looking for, please let us know, because I am happy to do a different type of talk about sleep. You would talk to your primary care provider or Swindells about referral to neurology or sleep medicine. I make podcasts for the Journal of Child Neurology and Child Neurology Open. And I want you to know that we have a whole series called What Your Pediatric Neurologist Wants You to Know, where I interview specialists on certain topics, on sleep, but also on ADHD and on headaches and seizures, neuropalliative care, neuroimmunology, neuromuscular disorders. We have POTS. We have a whole slew of them, and they are all available at this website. Or you can subscribe to the Sage Neurology and Neurosciences podcast. I think they're great. I love talking with these specialists. I learn a ton from them. and I think you will too. The Autism Speaks Sleep Toolkit is very useful for identifying issues with your child's sleep. And if you are looking to maybe be in a study for children with sleeping issues, there is a website called Better Nights, Better Days, and that's another good resource. So again, thank you very much, and thank you for spending your evening with me on St. Patrick's Day. I'm happy to take any questions.
Thank you, Dr. Christy. We really appreciate you sharing your knowledge and information with everyone. Again, I've gotten some feedback that our Q&A box is not working properly, so
Oh, no.
I apologize. That's a bit of a kink in this. However, what we would like to do is invite anyone who has a question or a comment to please email us at swindells@providence.org. That's SWINDELLS @providence.org. Or another option is to include questions in the post-event evaluation that will be sent to you tomorrow, along with the resources that Dr. Christy mentioned and a copy of the presentation from tonight. Again, apologies that feature is not working. I want to take this opportunity to also thank the Providence Children's Health Foundation and their generous donors for helping make events like this happen. Tomorrow I will be sending out an email again that will contain the event evaluation as well as a link to receive a certificate of attendance if that's something you're needing. We do use the information from the evaluation to help shape what information and what other events we want to bring forward. So I invite you to take a few minutes to please fill that out and also include any questions you might have. And then we can schedule another training where we can get these answers to these questions. Again, thank you so much for being here tonight. Please be on the lookout for that follow-up email, and we hope that you will be able to join us for future events. Thank you. And I'm ending.